Good evening, ladies and gentlemen. My name is Tariq Al-Tawil, and I'm a professor of orthopedics and traumatology at the National Institute of Neuromotor System in Cairo. My talk today will be on congenital radioulnar synostosis, which is a rare malformation in which there is an abnormal connection between the radius and ulna due to an embryonic failure of separation. Because the forearm bones separate at a time when the fetal forearm is in pronation, essentially all forearm synostoses are fixed in this position. It may be seen in conjunction with other syndromes, including Apert syndrome, acrocephalosyndactyly, Carpenter syndrome, acropolysydactyly, arthrogryposis, mandibulofacial dysostosis, Klinefelter syndrome, and Poland anomaly. It may be seen with other anomalies, cardiovascular, thoracic, genitourinary anomalies, cephalic, as well as other musculoskeletal anomalies. Usually involves the proximal ends of the radius and ulna, most often fixing the forearm in pronation, more often bilateral than unilateral. It is bilateral in 80% of the cases, and there is a positive family history in 20% of cases, and it is transmitted on the paternal side of the family. From this drawing on your left-hand side, there is full pronation supination and mid-bone of the forearm. On the right hand, there is almost minimal movement, and it comes actually from the small bones of the wrist, but there is no movement at all between the radius and ulna. As we mentioned before, about 1/5 of the children have positive family history. Can also be part of an underlying syndrome or developmental anomalies. And you can see from these x-rays the almost complete proximal fusion of the two bones together. The diagnosis is often delayed, and patients frequently lack functional complaints when the position of the fixed pronation is moderate and carpal compensatory hypermobility is adequate. Most patients do have functional limitations related to the synostosis, including difficulty using spoons, pencils, buckling belts, fastening buttons, and grasping small objects. Some patients have reported difficulty with sports. It's a congenital anomaly, so the facial tissues are short and their fibers are abnormally directed. The interosseous membrane is narrow, and the supinator muscles may be abnormal or even absent. There are two classifications for the anomaly. The first is that of the Takajian, and the other one is Clare and Omer, which actually divided it into fibrous and osseous, and the osseous into further three types, whether with a reduced head or the other two types with dislocated head, whether anteriorly or posterior. And as you can see from the X-ray here, the head is dislocated anteriorly. And very rarely there could be synostosis both proximally and distally in the two bones. Surgery is not recommended for most patients because the deformity typically is not disabling enough to justify an extensive operation. Motion of the shoulder, especially when the head is extended, compensates well for the deformity in most children. This child can ride, and actually we did not operate on him as he is managing well. Wait for the child to grow up enough for functional assessment. I believe it's important as well as to know whether the child is left or right-handed, as for the right hand, usually should be kept in pronation, while we keep the left hand in supination, mainly for hygiene and other functions. There is no consensus on treatment selection and surgical indications for congenital proximal radioulnar synostosis. Several surgical techniques have been described, but the outcomes are still uncertain. Surgery has its complications, and among them is recurrence of the synostosis in case you decide to separate the two bones. The recurrence is extremely very high in the literature, and you may not have sufficient supination, compartment syndrome, nerve palsy, vascular injuries, malunions, and non-unions. The anomalies in the forearm may be so widespread that sometimes no rotation would be possible, even if the radius and ulnar were separated and the interosseous membrane split through its whole length. In case you decide to separate, an MRI beforehand could be quite helpful. This is a girl that I operated on. She had bilateral synostosis, and we left the right forearm, while the left forearm was corrected in mid-supination. And on your right side, you see the 2 months post-op X-ray. The osteotomies were done in 2 different levels, and they are nicely united now. This child had correction. By this age, we knew that he is right-handed. He's using his right hand more than the left, and clever with it. So we decided to operate on the left one, and as you can see on the picture on the right side, we kept him in mid-supination. This is 2 months post-op, and this is the child a few years after. This is another child who had osteotomy for radius and ulna to do correction, and for fear of separation of the 2 fragments following the correction, we just fixed the 2 bones with percutaneous intramedullary K-wires, which were removed in 3 weeks' time, and we continued with the cast above the elbow for another 3 weeks. And this is the post-op X-ray. As you can see, the fibrous synostosis could obviously be diagnosed clinically, but on the X-ray, there is no connection between the 2 bones. And this may need the same operation of correcting pronation or supination as desired through osteotomizing the radius and ulna. This is a 16-year-old girl, and presented to us complaining of difficulty using her right hand. She has unilateral congenital radioulnar synostosis, and her forearm was kept in much of pronation, and she had an interesting complaint that she drops the keys and coins from her hand. She cannot properly grasp on them if somebody is giving them to her. And we did this operation. We actually osteotomized 1 bone only, which is the radius, as you can see, and fixed it with a narrow DCB with 3 screws to each fragment. She was quite happy with the result, and she was doing quite well. Kanaya and Ibaraki in 1998 described an operation where they separated the 2 bones and put in between a free vascularized fascio fat graft to prevent recurrence. And the comment of Campbell on this operation on 2021 that we have no experience with this technique. This is the paper by both of them in 1998. And in 2014, Sakamoto and colleagues described a modified osteotomy for canine procedure, and they used an interposition graft as well. In 2022, actually, there was a nice paper on treatment of congenital radioulnar synostosis using a free vascularized fascia lata graft, and the people kept on trying to separate the two bones and with interpositioning material or whatsoever to prevent reunion. This is the operation where they remove the synostosis bone and put a vascularized fascia lata graft in between. And they treated 16 cases with one recurrence of ankylosis. 2 cases had temporary radial palsy, and 1 case had blade breakage. They recommend the operation. I believe this is a rather difficult operation, and actually I personally have no experience with it. So our conclusion in this presentation that the congenital radioulnar synostosis is a rare finding, not only bony synostosis, but soft tissue affection as well. Most cases do not need surgical intervention. This is very important. You don't have to operate on every child that you meet. You see the capabilities and disabilities of the child, and you decide whether he needs further correction or not. Surgery, if needed, should be planned according to patient's need, left or right-handed. Operation, preferably before school age. 1-stage or 2-stage operation as surgeon's privilege. I personally prefer 1-stage operation, not allow the child to have another operation in 10 days. Mobilizing the synostosis with interposition flaps is still not popular and not an easy operation. Thank you.